I guess we'll get started. Good morning, good afternoon, good evening from wherever you are participating. Welcome to our first webinar on COVID-19 and stem cell transplantation, a worldwide perspective to a very important topic that is affecting the whole transplant community, both transplant teams that take care of patients, as well as donor registries, potential patients and donors, and scientific organizations. This webinar was organized by the Education and Dissemination Committee of the Worldwide Network for Blood and Marrow Transplantation. We are an international organization with 22 member organizations with the main goal to promote access and excellence in transplantation, in stem cell donation, in cellular therapy, and also accreditation. We are also an NGO to the World Health Organization. This webinar will be moderated by Professor Yoshihisa Kodera from the Aichi Medical University School of Medicine in Nagakute, Japan, and Professor Sebastian Galliano from the British Hospital in Montevideo, Uruguay. We have an excellent list of speakers, and I would like to take this opportunity to express our gratitude to all of you that you are willing and able to participate. So the first speaker will be Dr. Feras Alfraih from the King Faisal Hospital in Riyadh in Saudi Arabia. And he will speak on the management of donors during the pandemic. Then Professor Clarisee Machado from the Institute of Tropical Medicine in Sao Paulo in Brazil will continue and give us an overview on the transplant recipients and the challenges involved. Then it's a great honor and pleasure to announce Professor Huang from the Zhejiang University School of Medicine in Hangzhou in China. We all know that they had to undertake a tremendous effort to deal with the pandemic, and we are very grateful that he will share his experience with us. Then Professor Per Lungman from the Karolinska Hospital in Stockholm, Sweden, will give us an overview on the data that the WBMT registry has already collected on COVID-19 and stem cell transplant recipients. And then we will have Dr. Miguel Angel Perales from the Memorial Sloan Kettering Cancer Center in New York, also an area that is very much affected by the pandemic. And he will deal with issues surrounding chimeric antigen receptor T-cell therapy during the COVID-19 pandemic. After these presentations, we will have a panel discussion. And this is fairly unique that we have representatives from different continents and countries who will share their experience. So please go ahead, the next slide, please, and bring forward your questions during the webinar so that these excellent speakers will have then the opportunity to answer your questions. Here, you also have some information if you have technical problems. So at the end, during the panel discussion, we will try to answer as many questions as possible. With that, I would like to hand over to our moderators, and I'm looking forward to all the presentations. Thank you.
Thanks very much, Hildegard. We will start with our first presentation. Each speaker will represent one of the WBMT member societies. In this case, Feras Alfraih from Saudi Arabia will represent the Eastern Mediterranean bone marrow transplant group. So please, Feras, go ahead.
Thank you, Sebastian, and thank you for the organizing committee for inviting me. So I will try to address donors' perspectives during COVID-19 pandemic. As all of you know, COVID-19 pandemic is something that humanity has not seen in the last 100 years. Total confirmed cases of almost 4.2 million, and the casualties is more than 287 worldwide. It affected more than 200 countries in the world. Next, please. So during my talk, I'll try to focus on the impact directly on the donors, and it will be direct impact on the donors, also the impact on the medical resources dedicated for the donors, as well as healthcare workers. So COVID-19 during pandemic era has a direct impact on the availability of the donors. One is due to the psychological as well as stress impact, transportation and travel restriction, as well as safety of the donors. It's important to highlight what was the situation before the COVID-19 pandemic. This is from WMDA report, the availability of matched and related donor at verification typing for the centers who receive requests, more than 1,000 requests. So the availability of the donors at the VT stage varies from 26 up to 100%. Next. However, I mean, those who showed up for the VT, they are committed and with availability between 82 to 88%. So this is important to highlight what was the base, or what is the benchmark comparison before the COVID-19 pandemic. So if you ask anyone to go to a hospital, specifically patients, they will be afraid from going to the hospital. So keep in mind, if you ask a donor to come who's a healthy, this will be very concerning for him. That's why during such a pandemic, we have to come up with different solutions and strategies. So some examples is, instead of having the donors coming to the institutions, perhaps we can send healthcare workers to the institution. Important to have effective communications to relieve the stress and the anxiety of the donors. The use of the telemedicine is very important, and many organizations now accelerated their telemedicine programs due to the COVID-19 pandemic. Countries and healthcare regulators try to fight COVID-19 spread by applying restrictions on the transportation as well as in the travel. To overcome that, cryopreservation has been raised as a possible option. Cryopreservation, is very well used extensively in autologous stem cell transplantation. However, before COVID-19 era, if you look at the previous data, the utilization in allo HSCT was less than 2%. Why there was underutilization of cryopreservation in the past? There are many concerns. First concern was a delay in neutrophil engraftment or platelet engraftment. However, if you review the literature, I mean, it's a controversial. There might be some concern about platelet engraftment. However, it is not a major. The second concern is transfusion reaction, also from the use of DMCO. However, again, most of the reaction happened. Most of the reaction were either mild. Very few reactions were severe. There is a risk of bacterial contamination, but also if you review literature, I mean, very few of bacterial contamination led to bacteremia or sepsis. Other important issue if in the past that if we do cryopreservation, we will end it on over collecting unnecessary stem cell products which will not be used in future. There is a very nice paper by Dr. Hamadan et al. Looking at the CIBMTR data on the impact of cryopreservation for patients who used BTCY. So there was no significantly impact in overall survival, neither in chronic GVHD. Next, please. Just to highlight that currently with the COVID-19 pandemic, it's recommended to use cryopreservation. NMDB specifically required cryopreservation for all MUDs since March 23rd. WMDA recommended cryopreservation if possible. However, WMDA put some conditions. Next slide. Important conditions before using cryopreservation is that effective communication between the transplant center and the donor center, and it has to be written to avoid any miscommunication. Important point is that stem cell count has to be measured before the start of the conditioning. Cryopreservation might affect the stem cell count at very small percentage. Validity of the assays has to be in place to evaluate the thawing of the cellular products. Another important is an early arrangement of specialized courier for transportation of cryopreserved stem cell product. That's why that you have to use a probably different courier, or you have to double check with the courier that you are dealing with. Probably you have to communicate or work with the cord banks, because all the cord banks usually shipped using dry shipper. So moving next to the safety of the donors. Next, please. So whenever we have a donor, number one is for the 4 weeks before the collection, the donor has to be very strict in applying the safety, hygiene, and social isolation. For screening of this, assessment of the donor should include screening for symptoms of COVID-19. The test should be done in PCR and not only immunoglobulin. If the donor is positive, he should be excluded from the donation. The question is for how long he should be excluded. ASTC recommended 28 days, while EBMT, British Society of BMT, recommended 3 months. The second part is, after assessing the symptoms, is to look at the risk factors, whether the donor was in contact with a COVID patient, or he lives or traveled in an area with high risk of COVID-19. If this is the case, donor will be deferred for 28 days. Donors, post-donation, it is important not to forget contacting the donor, specifically in the first 14 days, to ensure that he did not develop any symptoms suggestive of COVID-19. Should we do COVID-19 PCR test before donation or before the collection? So FDA, the US FDA, does not recommend that. However, it is practiced frequently in many centers and recommended by EBMT and France Society. Again, as I mentioned, is COVID-19 transmittable by stem cell product or blood product? Currently, there is no evidence of that. Switching to the medical resources, currently the healthcare systems has been disrupted with the COVID-19. The demand of healthcare resources is much higher than the available resources. Because of that, there are different ethical values and principles that has to be taken into account when we are dealing with donors. Next, please. So some of the ethical principle includes treating people equally, which is important. However, during COVID-19 is not practical. Maximizing benefits is an important principle. Next, please. Giving priority to the sickest patients also is an important principle. And last is reward instrument value, which is specifically giving priority for research directed to the COVID or treatment for healthcare providers. Next, please. So keeping that in mind, how can we utilize medical resources for donors in a better way during COVID-19? The question will be, shall we go with peripheral blood collection or bone marrow collection for stem cell donors? Next. So there are important points to highlight. Number one will be the resource utilization. So if you are going for a harvest, you will be utilizing an OR slot, a ventilator, and an anesthetist. If you look at the peripheral blood, the resource utilization is less. If you look into the stem cell counts, frequently the count of the product after harvest is less than peripheral blood. So if the product will undergo cryopreservation, expect further reduction in the count, which might be a problem. Exposure risk at healthcare facility, usually the risk in the bone marrow harvest will be less because the procedure itself is shorter, usually less than an hour versus 4 hours for the apheresis. However, keep in mind that individualization has to be taken into account. For example, if you have a collection center which is outside healthcare facility or outside the hospital, maybe the exposure risk will be less. Overall, I mean, it's recommended that to try to limit the use of bone marrow harvest as much as possible during COVID-19. Lastly, I just want to point out that during such a pandemic, the healthcare worker in HSCT are scarce, and COVID-19 also reduced the manpower globally by giving medical exemptions to those who are above 60, for those who are pregnant, those who are immunosuppressive. That's why we have to keep that in mind, that the workforces currently are less than before. If you look at WMDA reports in 2018, so this is made specifically for the MUD. So there were donors who were had samples collected within 2 weeks. However, out of those 52,000, how many of them ended up going for workup? It was only 25,000, which is less than 50%. If you look at how many further cancellation happened, it was 13%. The reason for cancellation varies. Some might be donor related, some might be patient related. However, I would like to highlight sometimes some of the cancellations, either of workup or the donation, are avoidable. And we can predict that from the beginning. So we try to minimize the activation of donors if it was unnecessary. And I think that was my last slide, and thank you.
Thanks very much, Feras, for your presentation. Now we switch to the second speaker. She's Clarisee Machado. Clarisee, she's from Brazil. She's a virologist. She works at the Tropical Institute in Diseases in Sao Paulo, Brazil. And she has designed the guidelines for the transplant patients during this pandemic. for the Brazilian society that we are also using in other Latin American countries. Clarisee will represent the Latin American bone marrow transplant group. So please, Clarisee.
Hello, good morning. Thank you. Good morning, Brazil. Thank you, Sebastian, for the presentation and for the invitation. And I'll comment on the current recommendation for stem cell transplant centers in Latin America and some problems that we may face during the pandemic. These are the proposed measures that for the control of the pandemic. We have to pay attention to addition to hygiene procedures, social distancing, increase the number of tests for personnel and for patients, and without losing sight of the economy, what is a problem. Due to the inequity, social inequity that we have in Latin America, the next please, even simple measures such as washing hands may be a challenge. As you can see in this picture, these are sinks that were installed in the streets for homeless population. This population itself initiative. And also we have the problem of rationing of clean water in the peripheral areas of the big cities, in many of big cities in Latin America. Next, please. Other recommendation that is social isolation and social distancing. The media advertises stay home, stay safe. But how safe can these people be living in these housing conditions? These are cities, slums in Sao Paulo, Santiago, and Buenos Aires. Big cities in Latin America. Next. Also, the problem of money, getting money. The pandemic has hit harder the people who had lost income during the pandemic, those who work every day to eat and to drink. Local government has provided some financial support. This vary according to country. It's already around $100 a month. But we have had problems in the logistics of releasing this money, what has resulted in long lines at banks, which is completely against what we recommend about social distancing. Next. As you can see, even with as you show in the arrows, the spots marked on the floor, showing where people should stand, the low level of education and the comprehension of sanitary instructions made them disregard instructions and disregard social distance. Next. These are the lines to get money. Also, we had another problem that are the political crisis that should be put aside, but it's really disturbing the controlling of the pandemic. At this moment, what we need is coordinate task force and empathy from the government. And now we have such as provide hospital beds, ICU, ventilators, hire staff, and so on. And we have seen good things like the field hospitals that have been built, and this is good. But we also have unpleasant things like and lack of empathy, like the president of Brazil saying, so what, when asked about the increased number of deaths. So this is unacceptable, and I made most Brazilians feel ashamed. Fortunately for stem cell transplant center, most of the recommendations to control pandemic are generally followed in stem cell transplant center due to the immunosuppressive condition of the patient. I'll comment on the current recommendations and some problems that we have faced, mainly in public hospitals, stem cell transplant centers from public hospitals. Because the social inequity is completely different stem cell transplant in a private hospital than a stem cell transplant center in public hospitals. The problems are different. Concerned to this stem cell transplant recipient, most of the recommendations have been followed without problems, such as remove the patient from a positive pressure room, or to perform a tomography. All these recommendations have been followed. Next. The same can be said about the donor. Most of the recommendations have been followed. We have in some centers, especially in public centers, we still have, although approved by the government, we don't have enough tests, and sometimes the donor cannot be tested and have to just have to stay at home and make sure that the donor have been protected 28 days before donation. Next. Also, for stem cell transplant centers, most of the recommendations have been followed. What we are separating COVID areas and non-COVID areas. This is not a problem, but sometimes the dedicated staff to each areas may be a problem because of lack of personnel. Many healthcare workers getting infected and having to be at home. So this sometimes has represented a problem. And also for the visitors and accompanying persons in the room, sometimes we don't have tests, or because of lack of tests worldwide, we have this phase, but it's improving now. But in some centers, health insurance do not pay for this test, so they can't do it. Next. For transplant candidates, the same. We have a problem here concerned to centers that are patients live far from the stem cell transplant center, so they have to move to the city where the transplant center is located, and in these places they have to stay in support homes or support houses for the transplant patients, and not always is easy to manage the social distancing or social isolation of the patients of the candidates in these houses. Also, the one before, please. Concern to the other problem is the problem of the tests, and sometimes when we have a candidate with a high-risk disease that we can't defer the transplant for longer time. The lack of tests sometimes made us to prolong the time of the deferral because of the lack of the tests. So it's another problem that we are facing. Next. And finally, as you can see by the red marks, the greatest problem has been with the healthcare workers. The lack of tests made sometimes the healthcare workers stay longer at home because we cannot test them to return to work, to have a safe return to work, and have to stay longer at home. Also, a huge problem has been the shortage of personal protective equipment and shortage of staff that are getting ill. Very sad, sometimes they had to improvise masks or reuse masks, what is completely not recommended. So the healthcare work has suffered more in stressing situation, and we're really very worried about them. And in conclusion, next please. I think that the capacity of stem cell transplant center to comply with the recommendation is heterogeneous in Latin America due to the social inequity that I mentioned. Still have a delay in implementing approved measures and in the acquisition of essential items that we need to manage the pandemic. And healthcare professionals have been most affected due to the lack of testing, PPE, and shortage of staff to reorganize the shifts. Thank you.
Okay, thank you, Professor Machado. It's a very interesting presentation. And as a next speaker, we invite Dr. Huang, the first affiliated hospital, Zhejiang University School of Medicine, Hangzhou, China. He will present the Chinese experience. So, Professor Huang, please.
Okay, thank you, Professor Cordella, and thank you, organizer of the WBMT meeting. My pleasures, I'd like to share all some experience. And we all know that COVID-19 is a global pandemic disease. And since January and China and the outbreak in the Wuhan, and then my hometown is Hangzhou near Shanghai. And for such the patients and all the campers, because all the first every hospital, Zhejiang University, all the hospital is special hospital for such the COVID-19 patients. So we have the special campus. All the slides shows all the new campus and special for the COVID-19 patients. And one building for our staff, doctor and nurses, and another building for the diagnosis and suspicious patients, and one building for the ICU, and the total is 58 beds, and another building for the administration building. Please next. So all the total have about the 200 cases, including the severe and the very severe patients. We have to treat such patients. And until the February 14, and because China's Wuhan is a very severe condition, so I have to, we have to organize a volunteer doctor and nurses. Total is 140 volunteer go to the Wuhan. I, as the president of the hospital, will organize such the group go to Wuhan. We stayed in Wuhan about 2 months. And totally we have treated about the 300 cases of the COVID-19. So in all the Hangzhou, in all the hospital, we treated such patients and COVID-19. And under the COVID-19, 2 patients performed the lung transplantation recipient because it's the COVID-19 patient's dysfunction of the experiment, the recipient. And also we have the new baby, and for the COVID-19 patients, because the patient is pregnancy and admission or the hospital, and then have the new baby. And the artificial liver support system for the CIS of the COVID-19 patients. Next. In China, there are some hematological patients suffer from the COVID-19. Unfortunately, such the patients all the occurs in the Wuhan, because Wuhan is the pandemic center. There are the total is 29 cases of the patients with the hematological disorder, including the pediatric acute lymphocytic leukemia, breast anemia, and chronic myelogenous leukemia, and myelodysplasia syndrome, and the plasma cell myeloma, and acute leukemias. And for such the patients, we can see the case of fatalities later in persons with the hematological disease, infection with the COVID-19, and the high deaths total is 6 deaths in the 11 patients. A similar high cases of fertility later is reported as of 8 days among the 13 patients with hematological cancers with the COVID-19. Next. So how can we deal the transplantation? Because in our hospital and the Wuhan hospital, and we under the pandemic, and the optimization of the screen and the admissions process is very important. We set up the fever clinic of the hospital, and the independent area standardized the procedures, the 3 zones of the 3 passengers. For the fever patients, and first we will detect the COVID-19, and with the PCR and the antibody and the chest CT scan. And if such the patient is diagnosed the COVID-19, and we will transfer to the new campus with the transplantation of the patients, the negative pressure ambulance, and the PPE for the ambulance attendants. And the way we are assembling such patients is the new campus. Please, next. So transplantations activities of our center continue, such as the pandemic areas. And over the past 3 months, and 49 patients received transplantation, including the 39 from the haploidentical stem cell transplantation, 4 from haploidentical siblings, and 1 from the matched unrelated donor, and 5 cases received autologous stem cell transplantation. However, from the high peak time, from the January 24 to the middle of the March, so all patients' cities have faced the risk of the explosive split, COVID-19. With therefore the diphtheria planned hematopoietic stem cell transplantation, just only continue to perform the patients already in the laminar area, airflow, clean walls. And fortunately, all the patients, no patients have been infected with the COVID-19. Next. So we have some of the measures and the prevention of the COVID-19. And the pre-transplantation management of the hematopoietic stem cell transplantation, and the high community prevalence areas, we will suggest the diphtheria planned transplantation. For the low community prevalence area, and for another urgent transplantation cases, and first we screen for the COVID-19. And then we will screen such the patients with the longer CT scan and the qPCR, the antigen detection and the detection of the serum antibody. And if the negative, we will perform the planned transplantation. Next, please. So the pre-transplantation recommendation, and the recipient should home isolation for 14 days, the pre-transplantation. And the recipients should be screened, and should have the 2 more consequently negative tests more than 24 hours. And if the transplant candidate is close contact with infection patients, persons with COVID-19, and should be delayed 14 days to 21 days from the last contact and the potential recipient monitored for the COVID-19 infection. In patients with advanced or the high-risk disease and a positive PCR test, and the transplant should be delayed until the more than 2 consecutive negative of the PCR test more than 1 week apart. In persons with a low-risk disease, a 3 months delay is recommended for such patients. Next. So for the recipient donor and for the patients and the donor screen, and the longer CT scan should be reported to have the diagnostic sensitive about the 97%. Positive predicted value of the 65% according to some report. And also the RT-PCR for the COVID-19 is widely used and recommended. It has limitations such as the short detection windows from the nozzle swabber and the close contamination and the false negative. So the positive rate of the RT-PCR assay are just about the 50 to 70%. So the antibody test may be helpful for the diagnosis of the suspected patients with the negative RT-PCR results. And the Chinese data suggested that within 19 days after the symptom onset, 100% of the patients tested positive for the antivirus IgG. The serial conversions of the IgG and the IgM occurs simultaneously or sequentially. Both the IgG and the IgM titles the plateaus within 6 days after the serial conversion. Next. Please, next slides. And under the peri, last slides, please. No, last slides. Yeah, last slides, not the next. Yeah, last slide, please. Yeah. Okay, thank you. So next, please. Yeah. So peri-hematopoietic stem cell transplantation. And we have evaluated the patients. And first, the recipient should manage the structure, the protective isolation. The waste should be stopped. If with the clinical manifestation, rapid diagnosis with the COVID-19 and should be performed. The only one designed and the family members is permitted to carry the patients and should be screened for the COVID-19. And for such the unrelated donor transplantation and haplotransplantation. So because it's unrelated transplantation, where the challenge just like the transfusion. So with the shipping and the cryopreservation of the donor graft are recommended. And also we recommended the alternative haploidentical stem cell transplantation donors should be backup. For the related donors, and also we suggest to have the alternative haplotransplantation donors or the haplo donors in the liquid nitrogen cryopreservation as suggested. Next. Post-hematopoietic stem cell transplantation, we should educate the patients and all family members on the instruction regarding the isolation and the preventive measures. The self-isolation and home and minimize the number of the family members to visit. And the telemedicine visit or the online visits recommended. So explore ways for the patients have the blood test away for the busy area in hospital. Next, please. If the patients suffer from the COVID-19, and we should end first diagnosis with the long CT scan and the PCR and the chronic, the serious antibody. And we should be differentiations with another virus infections, and just like as the CMVs, another virus. Next, please. For the diagnosis and the clinical classification, and according to the guideline of the China, we have the differentiate the minor and the modalities and severe and critical severe. And all hospital, all the patients is including the severe and critical critically severe patients. And we should some the support with the ventilators or the another support methods. Next, please. Antivirus treatment. Also, we have this evidence, the efficacy of the antivirus, and in all the experience at that time, we have combined and some of the antivirus medicines. Next. So for the dysfunction of the coagulation, also should be careful for such as COVID-19 patients. And according to the report, 4% of patients experience reactive thrombocytosis disseminated intrasphicular coagulations across ischemias and the septal inflammation. And for the transplantations should be differentiated with the SOS and the TMA. Next. So such as above is all the experience with there such as the preventions, patients, and under the expand the COVID-19 pandemics, we perform the haplotransplantation. Thank you very much for your attention.
So thank you, Dr. Hafan.